will be introduced by my co-chair, Professor Beladi.
Okay, next talk will be optimal dual antiplatelet treatment, DAPT, duration following drug-eluting stents with bioabsorbable polymer, abluminal coating. This is a study will be presented by Dr. Nakamura from Toho University in Tokyo. It's a great effort to put together a bunch of hospitals and patients. Please, Dr. Nakamura.
Thank you, Chairperson. Today I will present the NIPPON randomized study data. This is my COI disclosure. As you know, the optimal duration of dual antiplatelet therapy after drug-eluting stent deployment remains controversial. Some trials demonstrated longer DAPT is better compared with the short DAPT. Another trial demonstrated short DAPT is enough after stenting. So, on the other hand, previously talking about that, the newer stent, the event risk is coming better compared with the first generation drug-eluting stent. Therefore, a combination of short DAPT and newer DAS should be able to minimize the incidence of thrombotic event and bleeding complications simultaneously. NIPPON trial is a multi-center randomized study to test a non-inferiority of 6-month DAPT compared with the 18-month DAPT following novel stent with bioabsorbable polymer and abluminal coating. This slide shows you the flow chart of NIPPON trial. A total of 1,375 patients was enrolled and randomized to two groups at a ratio 1:1, 18-month DAPT and 6-month DAPT. Unfortunately, this trial prematurely terminated due to the interim analysis demonstrated lower event rate than expected and slow enrollment of trial. We decided to terminate this trial. At this moment, the duration of DAPT was left on physician's decision. Therefore, we excluded patient 1,003 patients. In these patients, the follow-up period was less than 18 months at the time of terminator enrollment. We analyzed 2,772 patients. In these patients, 18 months follow-up was eligible to complete at the time of terminator enrollment. This slide shows the patient background. Basically, there is no difference. Majority of the patient, target region was 60% was LAD, and B2C region was around 6 to 2/3. We have to say the majority of patients one vessel disease, 85.5% in 18-month group and 88% 6-month DAPT group. 3 vessel disease just limited to the less than 2%. Stent diameter less than 3 millimeter was around 35%, and the total mean stent length was 20 millimeter. In this cohort, diabetes was included 40%, and ACS patient was included around 30%. The primary endpoint is an NSCCE, including all-cause death, non-fatal MI, non-fatal stroke, and major bleeding. Major bleeding was defined in BAC 3 or BAC 5 and modified REPRESS 2 studies. The primary endpoint during 6 to 18 months is in this group. The event rate was 1.45%, and the short DAPT group 1.92%. Therefore, the difference between two groups is minus 0.46%. The lower limit of 95% CI is minus 1.48%. The pre-specified non-inferiority margin was minus 2.0%. Therefore, this trial meets a non-inferiority endpoint. In conclusion, 6-month DAPT was statistically non-inferior to 18-month DAPT in terms of net adverse clinical event, including all-cause death, non-fatal AMI, non-fatal stroke, and major bleeding. However, the results need to be interpreted with caution. Enrolled patient, relatively low-risk patient, and in this open-label design, many patients frequently cross over to DAPT. DAPT was crossover. Early termination and crossover to longer DAPT is relatively frequent. Thank you for your attention.
Dr. Nakamura, maybe you would explain to me, first of all, you have a tremendous effort in 130 hospitals in Japan. I can see, as you mentioned it in the last slide, the risk of the patients. I mean, there are 30% of patients are having acute coronary syndrome.
Exactly.
And so maybe for the audience, would you speculate in a couple of things? Number one, this would not challenge the guidelines for 1 year dual antiplatelet therapy for patients having acute coronary syndrome. And on the other side, I can see that you are using here clopidogrel and ticlopidine. I wonder how many patients or percentage of patients were in ticlopidine, since I realize in Japan has been prolonged use of ticlopidine over the rest of the world. But would you mind to explain this situation?
Actually, at this moment, the plasgrel and the ticagrelor not approved in Japan. Therefore, all patients were treated by clopidogrel, 100%.
Oh, I'm sorry. And okay, so going again to your findings, what would be your message? We have all been struggling about trials and guidelines for 1 year versus many trials saying that we don't need that long, except for acute coronary syndromes, just for the stenting. How would you extrapolate these findings to clinical practice in Japan, or recommendations for near future?
Unfortunately, power is not enough. Sub-analysis demonstrated in the patient with ACS, long DAPT, a little bit better compared with the short DAPT, and also stent number of the stent is related to the event rate, and also diabetes. In the patient with diabetes, longer DAPT may be better. However, interaction was not observed. However, I think the reason why is the power is not enough. However, I can say if the patient low risk only one vessel disease, one vessel disease treated by new drug-eluting stent length just limited to 20 millimeters. It's just one stent. Such kind of relatively low-risk patient, the short DAPT may be enough.
Sure.
I think the important message that we take out of your presentation is that a more individualized approach to dual antiplatelet therapy is more important than ever. We have new stents with abluminal coating that reduce the thrombotic risk. At the other hand, you have the very high-risk patients with multi-vessel disease, multiple stents, or older stents in which the thrombotic risk may be very high, and those would qualify for prolonged dual antiplatelet therapy. So in the past, we had a simple truth.
That's right.
Just the 12 months of dual antiplatelet inhibition after ACS, for example, or after stent placement, and today we take a more individualized approach. I think that's an important message for you.
Yeah, I completely agree with you.
We'll open to questions. Yeah, there is a question there.
Hi, I'm Michael Reardon with TCTMD. Can you explain why the enrollment was so slow in this trial? Was there a reluctance on the part of the patients or physicians to enroll?
Actually, during the enrollment, the DAPT study was published. After that, many physicians came down the motivation.
So you mean that DAP trial moved the physicians in Japan into longer period of...
Some physician.
And how would the bleeding interpret in that during this trial and so forth? Has been a source of debate.
Yeah, actually, the bleeding risk is a very complication, is a big issue for Japanese patient. Of course, in Asian people, the bleeding risk is a little bit higher compared with the European and US guy. However, still many physicians, after DAPT study, many should move to the longer DAPT. It's just a trend.
There is one more question.
Here, I'll follow up again. In Europe, how frequently is this stent used, sort of a proportion of patients? And the question, what's the protocol for therapy in those patients?
Nobody is a Japanese origin. And however, biosensors serve the same stent.
Yeah, I don't have the exact market analysis, of course, but there are several types of stents with abluminal resorbable coating on the market. One is the Nobori stent, which is also marketed here in Europe, and the other one is the Biomatrix stent from Biosensors, and they both share the same stent design with abluminal coating that is bioresorbable and seems to have a lower thrombotic risk.
Right. Second.
The standard treatment for stable patients is still 12 months. And as said earlier by my co-chair, the standard duration for dual antiplatelet therapy is 12 months after acute coronary syndrome. With Pegasus trial, there is a trend towards prolonging dual platelet inhibition in high-risk patients with multiple stents, multivessel disease, or very high thrombotic risk.
Maybe just to finalize, the newest stents, whether Nobori or the new generation stents, the results are superb, as you can see. So whenever you go for a trial, the number of patients needed to prove a difference is enormous. So this goes again in the same saying. You need a tremendous number of patients in order to see a difference. So I think it's been great. Thank you very much for your effort and presentation, and we'll keep on going.
Thank you.